So we're going to finish up with a couple of lectures now. One is going to be on lungs and pleura, and the other one is going to be on the extended views. And we're going to do this in the next half hour. So what is it that we want to gain when we do lung and pleural ultrasound? Basically, you want to make the same principle. Big diagnosis is here. We're talking about a pneumothorax, a pleural effusion. If you push it a little bit more, I can tell you, you can look at volume status of the lung if you want, the amount of water in the lung. I'm going to show you some images there. There are other things that you can look into, but they're much more finicky. I would say if you can see a big pleural effusion pneumothorax, that really helps you. And those are relatively easy things to diagnose. Okay? The probes that you are going to use for the lung are either the curvilinear probe, which is very similar to your cardiac probe. If you don't have that, you can use your cardiac probe. It doesn't matter. But the idea is that for this probe having a lower frequency, you can go deeper. So this is the probe you're going to use for the posterior part of the lung, or where your liver and spleen is. The linear probe, you're going to use it for the anterior parts of the lung. You want to have high resolution. There's surface structures. You're looking at the lung at its interface with the pleura. So you're going to use both probes to have imaging of the lung. And again, the lung is basically an organ that doesn't transmit sound waves, except if it's filled with water. And you take that to your advantage when you're making your assessment. The diaphragm and periosteum is very echogenic. I showed you an image before where the diaphragm is very bright. That's an easy point of reference. Liver, kidney, muscle is like the heart. Is isoechoic. And then when you have fluid, or for that matter blood, or even fat, those are the dark regions. That's when you have like dark images. Okay, just to give you an idea of what to expect when you echo your lung. And we're going to use the 2D or B mode, and we're going to use the M mode sometimes to look at the relationship of movement of tissue over time. And the easiest thing, you're going to get your linear probe, you're going to put it in a longitudinal orientation, and the marker is going to be towards the head of the patient. Okay? So the marker is towards the head of the patient, longitudinal, and you're going to basically start scanning different areas. There are protocols for scanning the lung that have different regions, okay? And you have scores that you can add and make a diagnosis of how much fluid the patient has, whatever. Again, that's not the intention of what I want to do. But you can see that you have anterior areas, you have like middle areas, and you have posterior areas. Okay, and you just have to scan it. And guess what? You can go to upper parts of the lung and lower parts of the lung. So I think if you divide everything in four, it's probably better. Anterior, posterior, and then upper and lower. And that really, and if you do it on both sides, you're scanning 8 zones of the lung, and that's probably plenty to make a diagnosis. Some authors have encouraged this approach instead of doing up to 28 points of scanning. That's a little bit too much in my opinion. Okay? And this is some of the definitions of what is called zone 1, zone 2, and zone 3. I really don't want to get fixated on this. I want to understand that you have to move your probe to get the images that you want. Okay? And again, the more anterior areas allow you to potentially make the diagnosis of pneumothorax and volume status. The zone 3 or more posterior windows is going to give you a better view of the diaphragm and the pleura and liver and spleen for that matter. And this is what I was telling you about. You put your probe longitudinal way, marker towards the head. And then you're going to get things like this. This dark region here is your rib. There's no echo imaging because the rib is blocking the ultrasound. Okay? So what you have in the middle is lung. This bright line is your pleural line. Okay? Again, if you look at this thing, it looks like a little bird or a bat. That's why it's called the bat sign. Okay? That's what I wanted to show up in the other one. The bat didn't show up. So you are relying now on artifacts to assess how the lung is. If the lung is basically dry and doesn't have any fluid around it, transmission is going to be compromised. So what you're seeing is a lot of artifacts. The first artifact you're going to see is A lines. Okay? The A line is defined, it probably originates from the pleura, the parietal pleura, or between the interface of the pleura and the lung. It's unclear what it is, but it's a very broad echogenic line, and it reverberates. So you have this line repeating itself at the same distance from the probe to the pleura and in succession down. So it's very easy to recognize when you see this. You see a bunch of lines, so you see a thick line. This is what is called an A line. As soon as the lung gets a little bit more water, let me see. Again, it's a A line, just to reiterate, this is a reverberation artifact, okay? And it's basically horizontal and equidistant from the pleural line, from the probe to the pleural line, and continues with the same distance going down. As I was saying, as the lung then fills up with a little bit of water, there might be some transmission of echo or ultrasound through the tissue. And that generates another set of lines. Again, this is how the A line looks again, just to continue with that. And again, when you don't have A lines, then you start thinking. Either you have fluid in the lung, or you have any of other these conditions. Again, and that's how you're going to play this game. You're going to look at different images to decide whether the lung is there or not, or whether the lung is consolidated or not, or whether you have fluid or not around the lung. Okay? Now you see this new pattern that you do the same thing. Rib here, rib here. This is your pleural line. And look at what's happening here. You have this B lines, okay? These are very bright lines that go all the way through the scan and tend to move with the sliding of the pleuras as well. They're called B lines or comet tails. Okay, they're very hyperechoic. You can have a few, you can have many of them, and again, depending on how many, you can make an inferences on the amount of fluid that the lung contains. So people have suggested if you have less than 3 B lines or comet tails in a particular sector, that lung doesn't have too much water. If it goes 5 or higher, it suggests that you have what we call an interstitial pattern. This can be a fibrotic lung, this can be a lung with pulmonary edema, okay? And you can use this to gauge where you are. Remember that there's a hydrostatic pressure gradient, and if you're scanning up here, as soon as you start going down, the B lines will show up even more clearly, because now you're going to areas of the lung that are seeing more hydrostatic pressure, hence they have more fluid. So again, it's a dynamic thing that you can follow. Some people have used these lines to follow up treatment. Give a dose of Lasix, the lung gets drier, the B lines should basically start getting smaller and smaller. And some people use this for like dialysis and things like that. Again, this is when your lung ultrasound becomes very fancy. You're gauging your volume status based on this, okay? This is an example. 1 B line here, you get like 4 B lines here, and look at this, there are a bunch of them together. Some people have said that you create a ratio of the areas covered by the B lines versus the rest, and again, you get an idea where you are, okay? But again, these are patterns you should be able to recognize. It should be easy. If you see 1 or 2 of these, that lung is fine. If you start seeing something like this, you say, And again, if you move further down, you may pick it up, and then you may get this pattern, okay? Very easy to recognize, okay? The other thing that you look for when you're doing the lung ultrasound is the sliding sign. Your pleurals are basically sliding with each other, and that generates a particular pattern that is almost pathognomonic of lung presence when you have that, if you ask me. So when your patient is decompensating, you don't know what's going on, the peak airway pressures are going up, the patient's fighting the vent. You put your probe, and you see sliding of the pleuras by the lung sliding sign. You can make the argument there's no pneumothorax there. And this is how it looks. Rib, rib. This is your parietal pleura. You see these little dots moving back and forth, like little ants moving? That's a sliding sign. And you can even see little comet tails. You see that? So you have this view. You can tell right away that there's lung underneath that probe. Look at this one. Okay? You got your rib, rib, your pleural here, and I don't know. There's no sliding there. Everything moves. You will see some movement of structures because, passively things get transmitted. but there's no lung sliding there. You just have to start thinking, could this be a pneumothorax? So again, I think when you put your linear probe and you're oriented the way I'm telling you, you're looking for certain particular things, a pleural line, lung sliding, and then if you apply the M mode that I'm going to show you in a second, you can then get certain particular patterns that also help you to establish a diagnosis. Okay? And these are things that you're going to be hearing more and more. At the beginning, it's a lot of stuff, but it's actually very simple. The first thing is the seashore sign, okay? Versus what we call the barcode sign. And all the things just try to give you a graphic representation of what to expect when you have different scenarios in terms of the image that appears. So what you do is you do the same image acquisition that you're doing with your linear probe, and then you turn on your M mode, okay? So look at what's happening here. Rib, your parietal pleura there, you get your M mode activated. And now look what happens here, okay? The tissue that doesn't move, which is your skin, fat, all those structures, basically generates little lines over time. They're not moving, just a line. The lung parenchyma underneath, as it's moving when you're breathing, creates this basically this image here, this hazy image that looks like sand. And these are little waves coming to the beach. That's why it's called the seashore sign. Okay? And it's very easy to recognize. Okay? If you have structures that doesn't move, lines show up. If the structures are moving under the beam, they're going to give you this hazy pattern or sand pattern. And you can see it here in action. Look at the parietal pleural. You see the sliding sign. You see the comet tail. If there's comet tail, there's lung underneath. So that helps you a lot. Now you put your M mode. Look at the lines here. Look at the waves hitting the sand here. Okay? Very easy to recognize. If you happen to have no lung underneath, you have a pneumothorax, look what happens. You put your M mode, and they're just lines, 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 lines. You don't have that hazy sand appearance that you have there. That's called the barcode sign, because it looks like a barcode, or the stratosphere sign, which is basically a reference to like airplanes flying high. When they leave those trails of water vapor on the atmosphere, they live like this little things. That's how they call it, why they call it the stratosphere sign. Okay? So again, lines, 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 lines. You don't have that grainy view. You don't have the sliding sign. You see that? So that tells you there's no lung underneath. So you starting to recognize patterns. You have this image, you have this image. Where's the pneumothorax? Right or left? There you are, because you have basically lines everywhere. Here you have the grainy appearance, that's the lung moving back and forth. Okay? Seashore sign, barcode sign. Okay? If you happen to catch the interface between the lung that is collapsed and the lung that is expanded, the pneumothorax is not complete. You have what we call a lung point. People say if you have a lung point, that's beautiful. So you have to basically move your probe until you find this. Okay? And this is how this looks. Look how beautiful. On the left, you see the sliding sign. You see the comet tails. And here you see nothing. You see just a reverberation and nothing's moving. That's a lung point. That's the interface between a pneumothorax and a lung that is expanded. Some people have said, can you quantify the amount of pneumothorax with this? Probably not. It's very hard because you're not getting a 3D assessment, you're just finding a point. So I don't think I haven't seen anybody really quantifying the amount of pneumothorax that you have 20% lung down, 40% down, whatever, based on the signs alone. Okay, so that's important. Let's say now we have fluid around the lung, or the lung is consolidated. It's have a pneumonia. Because of that, there's going to be a transmission pattern going through the tissue. Okay, these images that I'm going to show you are usually obtained by moving the probe further down and looking into the lung and pleural windows. Okay, marker usually up, and you scan it up and down. You're going to get the lung here, diaphragm, and your viscera underneath. Okay, and again, it's a little bit clear, but you see the diaphragm here. There's probably the liver here, and you see this dark area surrounding this structure here. Normally, the lung doesn't transmit ultrasound, but this image here suggests that this lung is consolidated or atelectatic, and is surrounded by fluid all around. Okay, so again, very easy, and I'm going to show you better images in a second. The same thing here. You get a little dark region here that you should not have. This lung here looks like tissue, looks like liver. The lung should not look like liver. Okay, so you know you have a problem there. This is the diaphragm here, and this is the viscera underneath. Look again, fluid. You can see some fibrin in here as well. Look at this lung. Doesn't look as dense, but this is not normal lung either. Okay, we have very good echogenic windows because it's being transmitted by all this fluid. Okay, so pleural effusions are very easy to diagnose. We use them all the time to drain, do taps in the ICU. The intervention radiologists do this. When you call intervention radiology to tap one of your effusions, that's what they're going to do. They put a probe, they find this, and they know how deep to go, so they just tap where fluid is. Okay, takes just a few seconds. Okay, or the other way around. You see what you think is an effusion on X-ray. You do your ultrasound, you find nothing. It's probably a consolidated lung or something else. Again, the echo will help you troubleshoot that right away. So again, when you're looking at the lung, you're looking at for certain particular signs. A lines, B lines, lung sliding, lung point, seashore, and barcode sign. Okay? It's a matter of doing this routinely. As you're doing your echo, let me tell you what I normally do for the sake of getting proficient with this. Every time I do a heart case, and I'm scanning my neck as my resident is getting ready, I usually do two things. One, I scan my neck just before I even prep the area, because I want sometimes my patients to have very little IJ or it's thrombosed, whatever. So before I even prep, I don't want to be prepping one area then finding that the IJ is gone or it's thrombosed, whatever. So I preemptively check both IJs before I do anything. And then I grab my probe and do a surface echo in 10 seconds. I go subcostal, go epical, parasternal, boom, 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 just to confirm sometimes the diagnosis, just for my own sake, just for the sake of the resident working with me that day, so they can do surface echo. So every case they do, besides getting TE, they get a surface echo. It takes 2 minutes. The machine is there, the probes are there. So you should take advantage of that. You should do that as a routine thing. So again, ultrasound is going to be good for pneumothorax, effusions. I think you can see consolidation or pulmonary edema, and I think this interstitial pattern can be very interesting. When you're starting to get a little bit more sophisticated with the use of the ultrasound, you can tell even volume status or amount of fluid in the lung based on the pattern that you're seeing on your B lines. Okay, any questions on the lung?